Hello, everyone, and thank you for your invitation. My name is Sara Hammerstad, endocrinologist at Oslo University Hospital. The topic of my talk is management of severe Graves' disease following alemtuzumab therapy in multiple sclerosis. And this talk is based on a clinical case. Multiple sclerosis and Graves' disease are both disorders which can be seen in young adulthood. Graves' disease is mainly affecting women. The incidence of Graves' disease is 0.21%. The incidence of hyperthyroidism during pregnancy is low, 0.2%, mainly Graves' disease. And fetal hyperthyroidism is seen in only 2% of these cases. The clinical case, this is a 36-year-old woman who was diagnosed with MS at the age of 29. And she was treated with different therapies, steroids, interferons, Gilenya. And due to disease activity, she was treated with alemtuzumab in 3 courses at the age of 32, 33, and 35 years old. Graves' disease was actually diagnosed during a routine control 4 weeks after the 3rd treatment course. She didn't present any signs of hyperthyroidism or endocrine ophthalmopathy. The levels of TRAb were at 13. The reference rate in our laboratory is below 1.8. She was treated with carbimazole. And a few months later, thyroid function tests were within reference range and TRAb levels were close to the upper reference range at 2.2. She had a pregnancy desire. According to the guidelines of the American Thyroid Association, there are different treatments which should be offered to patients with Graves' disease and who are seeking future pregnancy. The first choice is antithyroid drugs, MMI or PTU. There are very mild, very few mild side effects. Birth defects are seen with both MMI and PTU, lower rate with PTU, and therefore PTU is recommended during first trimester, while MMI is recommended during 2nd and 3rd trimester, because there has been some cases of hepatotoxicity by use of PTU. Radioactive iodine is easy to administrate, induces lifelong hypothyroidism. We know that it may induce a rising in antibody titers. And actually, we don't recommend pregnancy before 1 year after treatment. Thyroidectomy can be associated with some surgical complication, the need for some healing, and lifelong need for levothyroxine due to hypothyroidism. So in this case, she had a mild disease, low level of TRAb, so we decided to continue with antithyroid drug. As she had a pregnancy desire, carbimazole was switched to PTU 100 milligram daily, and she went through a successful IVF but had an early abortion. She conceived again shortly after, and in early pregnancy on 100 milligram PTU had quite nice thyroid functions test, T419, close to upper reference range, and TRAb levels at 3. So everything actually looked quite promising, but in gestational week 4, there was a quite increase in TRAb levels at 23, and T4 levels started to increase. The dose of PTO was gradually increased. So we were getting close to the second trimester. The levels of TRAb at this time was 187. Treatment was switched to carbimazole with increasing dose due to increasing levels of T4 levels. So in this case, we are confronted with a pregnant patient with high levels of TRAb. FT4 levels were quite within reference range. We know that in case of high levels, T4 can cross placenta, inducing fetal hyperthyroidism. TRAb can cross placenta, inducing fetal hyperthyroidism, and later neonatal hyperthyroidism. We know that blocking TRAbs exists. In this case, we were not sure if there were any percent of blocking TRAb. So the TRAb was tested in laboratory of Dr. Kalahi, and it shows that 90% of them were stimulating. Both PTU and carbimazole can cross placenta, inducing blocking fetal thyroid gland, and also birth defects and side effects. The fetus needed to be monitored. There was a risk of miscarriage, intrauterine growth restriction, fetal hyper or hypothyroidism, preeclampsia, preterm labor, low birth weight, prematurity, thyroid storm, heart failure, or at the worst case scenario, stillbirth. So in second trimester, we discussed this case with our endocrine surgeon if thyroidectomy should be performed due to very high levels of TRAb. Sonography showed a highly vascularized enlarged gland, and there was the risk of bleeding, nerve palsy, or hypoparathyroidism. TRAb will definitely persist for a few weeks, still continuing inducing fetal tyrotoxicosis, and taking into consideration that we will stop antithyroid drugs after surgery. So it would be difficult to monitor the levels of thyroid levels in fetus. There are some studies who has used radioiodine during pregnancy in Japan, but actually in Europe we don't use radioiodine during pregnancy. So here we decided just to continue the development of fetus during pregnancy and see. So the fetus was followed up regularly by a fetal medicine specialist every 4 weeks. The heart rate was normal, 130 to 150. Normal weight curve, estimated weight in gestational week 33 was 2.6 kilogram. And thyroid circumflex was normal size, and in week 39, 57, which is 60 percentile. We actually didn't perform any bone maturity, which is also recommended. So everything looked quite good. Estimated weight in gestational week 39 was 3.1 kilogram, but 1 week later the growth curve declined and the birth was induced. At that time, this woman gave birth to a small but healthy girl. The weight was 2.6. Normal heart rate, blood pressure, temperature, and glucose. At this time, we knew that there was high risk of perinatal tyrotoxicosis. The baby was tested for thyroid function. FT4 and FT3 were within the normal range, 15.3 and 3. There was a transitory increase in TSH at birth, and we had very high levels of TRAP, 240, which is actually the same level as the mother. So high risk of perinatal tyrotoxicosis, and the baby was referred to intensive care unit for monitoring. At this time, she got breast milk, but also some supplement milk, because in case tyrotoxicosis will occur, she will lose weight, and the fact that she already was underweight at birth. So here is the thyroid function test at birth. She was tested normal thyroid function until the day 5, where we saw a increase in thyroid hormone levels, and then symptoms started on day 8 with tachycardia and weight loss. So we started on propranolol and carbimazole mixture, and she was still in intensive care and tested regularly thyroid function, and carbimazole and propranolol were gradually decreased. The level of TRAP at birth was 230, day 829, and returned to normal after 6 weeks, where treatment was stopped. So this is actually a case of severe Graves' disease with very high levels of TRAP. Alemtuzumab is a anti-CD52 monoclonal antibodies, which is given in active relapsing remitting MS, is very efficient, induces depletion of T and B lymphocytes. The immunological side effects are ITP, occurs in 1 to 3% of cases, kidney diseases in 0.3%, but autoimmune thyroid diseases are very common and is seen in 40% of cases and occurs 61 months after last course of treatment. Excuse me. Most of the cases of autoimmune thyroid diseases is Graves' disease, 60 to 70%. Here is the guidelines for follow-up of patients who are treated with alemtuzumab. They need to be tested for thyroid function every 3 months during 4 years, and then every 12 months in case of symptoms. And treatment after the regular usual guidelines with antithyroid drugs. Usually Graves' disease or autoimmune thyroid diseases occur a few months after treatment when there is a lymphocyte remodeling. Pregnancy is actually not advised for 4 months after treatment with alemtuzumab. What we have seen is that TRAP levels are quite higher than in classical Graves' disease, and actually patients doesn't have the same symptoms than regular Graves' disease. Blocking TRAP has been seen, not so often, but it's reported, and it's important to check TRAP levels also in patients with hypothyroidism, as it should be tested in last trimester. There is need for close monitoring with an interdisciplinary approach to follow up the mother with fetus and pediatrician. So actually here we had a happy ending. the risk of fetal hyperthyroidism is high in Graves' disease with high levels of TRAP, PTU used in first trimester, carbimazole, methimazole, second and third. In case of TRAP, 3 times upper level limit. Also those with previously Graves' disease, there is need to check during last trimester and follow up. There is definitely a high risk of perinatal tyrotoxicosis, which is actually transient. So we just need to diagnose it. It appears 1 week after birth. So the regular screening test, which is done on day 2-3, may not diagnose it. So thyroid test should be done on day 3 to 5 and day 10. Remission here arrived after 6 weeks, clearance of TRAP, which actually fits good with the half-life of TRAP, which is 5 days. And a definitive therapy after birth should be recommended. We recommended thyroidectomy to this patient. This is my last slide. The mother, after birth, had an activation of Graves' disease, and the dose of carbimazole was increased. Almost 1 year after birth, she still presented very high levels of TRAP, and we recommended the thyroidectomy, but she postponed it. Well, happy ending this case. Thank you. I would like to thank my colleagues, Dr. Narheim, endocrinologist Dr. Silius, neurologist Dr. Husby, fetal medicine specialist Dr. Sørensen, pediatrician, and Dr. Pausen, endocrine surgeon. Thank you.